Hello and welcome to the May edition of My Macular and Me. I'm Kathy Yelf, the Chief Executive of the Macular Society, and it's great to have so very many people with us this evening. You are very welcome and thank you so much for joining us. These webinars are designed, of course, to bring you the very latest news about age-related macular degeneration and to give you a chance to hear from the leading experts on AMD and to put your questions to them directly. So in a moment, we will have the talk from tonight's guest. If you do have questions, please pop them into the chat and we will get to as many as we possibly can in the course of the session. Now, I know that many people with dry AMD are incredibly frustrated by the lack of a treatment for dry AMD. There are several drugs available now for wet age-related macular degeneration and other forms of macular disease, but still nothing for dry AMD. Is that about to change? My guest tonight is Professor Ian Pearce, who is a consultant ophthalmologist at the St Paul's Eye Unit in Liverpool. Ian has been a principal chief investigator for many national and international clinical trials of new eye treatments. And tonight he's going to tell us about a possible treatment for, yes, dry AMD. The technical name for the drug in question is pegcetacoplan, but it will be marketed under the brand name Syfovre. Ian, welcome back to My Macular and Me. It's lovely to have you with us again. Thank you very much indeed for joining us. This new treatment is potentially very exciting. The big question is, will it or when will it be available in the UK? Over to you, Ian, for your talk tonight. Thank you very much indeed.
Thank you, Kathy, and thank you very much for the kind invitation. I'm a great supporter of the Macular Society. I think you do wonderful work in not only promoting the interests of patients with macular disease in the UK and internationally, but I think also you're helping educate myself, my colleagues, and patients around the country affected with macular disorders. And so that's why I am delighted that I can join you this evening and try and give you my spin and my expertise in terms of the treatments as you've described. So you've set the scene perfectly. For over 15 years now, we've had anti-VEGF treatments, which are injections of drugs into the eye to treat wet macular degeneration. And as many of you know, that has revolutionized the treatment of wet macular degeneration. But for many, many years, we've been looking for treatments to treat dry macular degeneration. Now, as you're aware, dry macular degeneration often will develop as we get older into our 60s, 70s and 80s, and the incidence of that development gathers pace the older we get. And as we know, we're developing an older population as our demographics in our society change. And so this is a big issue for all of us facing those latter years in our life. Now, dry macular degeneration is, I wouldn't say it's completely normal, but if we all live old enough, we'll all get an element of wear and tear at the back of our eyes. Now, in certain patients, the dry macular degeneration progresses at a more rapid phase. And as I say, often that will end up with wet macular degeneration, where basically you get the worn out areas, little blood vessels will poke through the worn out areas, they will leak fluid and damage the retina, and hence the name wet. But if you've got dry macular degeneration gradually progressing and progressing and progressing, it doesn't always lead to these blood vessels poking through. Sometimes it just leads to rather patches of really severely worn out area. And I think if you think of it, is your eye is like a camera. The back of the camera, you have a film at the back of the camera. And if you imagine that film has patches that are just becoming very advanced areas of wearing out. And we call that atrophy. So that's where cells at the back of the eye have all of a sudden, they've developed over the many, many years of being very, very active and using sight throughout life. And they just stop functioning and they die away. And hence you get these patches of vision. So that's what we mean by dry macular degeneration. It's just a gradual wearing out. But there's a very, very advanced form of that known as geographic atrophy. And geographic refers to that it's in certain patches. It's almost like a map. You can draw a line around where these areas of very worn out atrophic areas are. So we could term that geographic atrophy, and it's the late stage of advanced dry macular degeneration. So the treatment I'm going to speak about this evening, or potential treatment, Syfovre, is aimed at that group of dry macular degeneration. It's not for all the early phases at the moment. It's not for the majority of patients, but there's a select group of patients who will potentially benefit from this new treatment. Now, we don't exactly know how many of patients are actually in the UK who will be eligible. And the reason we don't know is, as you probably found, and many of the people on the call will find, is that we haven't been doing anything in the UK specifically directed at these advanced phases for many, many years, because patients would come along, they'd be referred by their optician or the general practitioner. We're saying that we're struggling with vision. I've got these patches. I'm losing vision in my vision. We would see them and say, well, I'm very sorry, you've got advanced dry macular degeneration. And we would try to direct that patient to magnifiers, help with magnifying and low visual aids, but really we weren't able to do anything. So often those patients were discharged from the hospital eye service back to the community. So it's very difficult for ophthalmologists to actually be sure how many patients actually have this advanced form of dry macula known as geographic atrophy. We think it's somewhere in the region of around about 40,000. Well, what does that actually mean to us? Well, what that means is that every year about 40,000 patients are developing this late phase. That equates to about 100 patients a day. So this is a real big issue for facing all of us, facing all the patients in the UK. About 100 patients per day developing this dry, advanced form of geographic atrophy. So we've been trying to investigate many different ways of how to slow down the progression and potentially providing a benefit for those 100 patients every day that come through our door. So many research groups throughout the world have looked at many different ways, and thankfully there's a lot of interest in this area, and so therefore there are lots of different targets or potential targets for treatment. The one that's really gathered pace in the last year or two is targeting a particular pathway in our immune system known as the complement pathway. And what that is if you imagine you've got this gradual wear and tear at the back of the eye, and you're getting these cells and these patches of retina dying off, what appears to happen is that build-up and that gradual progression stimulates an inflammatory reaction in the eye. Now, the eye doesn't go red and the eye doesn't become full of inflammatory cells, but there's definitely a cellular layer, an immune reaction happening. And what we believe is happening is that certain parts of the immune system, and the complement system is a part of the immune system, is overactivated. And so you get an upregulation, or you get an overactivation of these chemicals in the eye, which then attack the cells and cause further cell death and leading to these patches of so-called atrophy. So we have a worn out area, inflammatory reaction, then more cells dying, leading to a further area of atrophy and patchy vision. So that immune pathway, the complement pathway, has been an area of interest for a few decades now, but particularly in dry macular degeneration over the last decade, we've seen advances in our understanding. Now, about 5 years ago, we investigated a drug called lampazumab, which was trying to block part of that immune pathway, and it was given by injections into the eye. And we gave that for, in the initial trials, it was very hopeful, but the later trials to see whether it would actually work in large numbers of patients failed, and we didn't really see a benefit. And we were concerned that that might be the end of the interest in geographic atrophy, thinking, well, it may be too far. But thankfully, several companies still committed a lot of resources and a lot of intellectual property and power to investigate it further. And one of those companies is a company called Apellis, and they've developed a drug. So you refer to it correctly as pegcetaplam. It's basically a drug we inject into the eye. And what it does is it blocks part of the complement system in the eye, stops that immune reaction, and slows down wearing, these patches of atrophy, or these patches of wearing and tearing at the back of the eye. So pegcetacoplan has been injected in the eye. It's been studied in major clinical trials now, and we've just, in the last few years, finished a large global study known as the Oaks and Derby studies throughout the world. And what we've been able to show is that injections of this new drug significantly reduce the progression of the atrophy. And that's led to its approval as a regulated drug in the USA. So if you live in Boston or New York or Chicago, you could go along to your ophthalmologist with a condition of advanced dry macular degeneration, known as geographic atrophy, and you would potentially be available to have a treatment to slow down the progression of the remaining atrophy. You don't halt it, you don't reverse it, unfortunately, but you slow down the progression. And that's, as I say, led to this, the studies led to the regulation and the approval by the FDA, which is the licensing authority for drugs in the USA. And they've been given a license earlier this year in February in the USA for this treatment. And it's known as the trade name for it will be Syfovre. And as I say, it's available in the US at the moment. So what's happening in the rest of the world is now the company is presenting that information to different regulatory bodies, including the UK and the rest of Europe, and saying to them, will you consider this as a licensed treatment? And we're very hopeful that the licensing authorities, both in Europe and in the UK, will approve it, just as they've done in the US. Now, we don't know, there's not a guarantee it will be approved, but we're very, very optimistic and we're hopeful. When will that be? It's difficult to say, and I don't want to tempt fate, but we're hoping that within the next 6 to 9 months that we will get approval for the treatment as a licensed agent in the eye in the UK. Then, of course, what will happen is NICE will look at it. Once it's been approved and considered as an effective treatment, NICE, as with all the drugs that we're treating for macular degeneration, will look at it and say, okay, we can see it's effective, but we have to look at how cost effective it is. Can we afford it as a nation to provide it? And they compare that. They do it in a very rigorous manner, and they do it in a very fair manner. They look at all the available data and they say, well, we can afford it for this group of patients, or we're not sure if it's cost effective if we give it to a large group of patients. So we'll have to go through all that process, and the Macular Society will be key. The Macular Society are often invited to be as key stakeholders and key representatives of patients in the UK. So the Macular Society will be considered as a stakeholder in that process, and will hopefully be able to analyse the information that we have at that stage and say, right, okay, we can afford it for these group of patients. So that's what I foresee and hope in the next 6 to 9 months. Then, so get regulation, have it, Syfovre available in the UK, and then hopefully available on the NHS, so that the vast majority of our patients in the UK will have access to it. But as I say, it doesn't halt. It doesn't halt the geographic atrophy. It slows it down, and it's variable. What we find with patients with geographic atrophy is that some people are advancing very, very quickly, and some people advance a little bit more slowly. And so one of the things we're going to be looking at is trying to identify patients, even now, even though we've not got the drug licensed in the UK, and even though it's not gone through the licensing or NICE, we've still, as I said, seen these patients in our clinics that we used to discharge. Well, now we're looking at it a little bit differently as ophthalmologists. We're going, okay, let's categorize, let's find out exactly what type of geographic atrophy it is, how large it is, how close to the center of the vision, what's happened with the other eye as the other eye advanced, and if we lost vision, that's obviously a bad omen for what might happen in the remaining eye. So all these factors now will be documenting, recording, and trying to put in place a system to go, okay, if a treatment becomes available, this patient might be suitable or would be the ideal candidate, whereas this patient may need monitoring. If they're very slowly developing, they may not need the treatment. If they're very rapidly progressing and they've still got useful vision, then they may well be a very critical patient that we would want to provide access to the treatment. The treatment is an injection into the eye, just as we've done with wet macular degeneration. Now, for many patients who have never had an injection, the thought of that is quite concerning. Many patients really, and every day we face this when we presently are managing wet macular degeneration. But all I can say is I can reassure patients that we've given thousands and thousands of injections just this week in the UK. We've had 15 years of experience of providing these injections on a regular basis for wet macular degeneration. And in my experience, patients tolerate it very, very well. We freeze the eye with lots of little drops. So you come in, you'll have the drops in the eye to just take away any discomfort. We use something, just hold the eyelid open. You're looking in the opposite direction. It's a little press on the eye and the drug is injected. So it's a momentarily thing. No, I'm not going to say that, I would look forward to that, or many of us would would clearly volunteer for that. But what I can say is that the vast majority of patients tolerate it very well. They come back for regular treatment, and it's the fear rather than the actual injection itself. And once you've had an injection, you realize, okay, that's not as bad. Obviously, we would prefer it that this was an eye drop or a tablet rather than an injection. But for the time being, this is an injection. In the studies, we injected patients every month or every 2 months, and we don't know exactly what the regulation in the UK or Europe will be. In the US, you're allowed to give it every month or every 2 months, and that will be up to the patients and the physicians to try to decide what the patient needs. But we don't know exactly what it will be, the licensing in Europe. So I have to say we'll have to wait and see. It won't be a surprise if it's every month or every 2 months, but it's going to be long term. This is not a short-term treatment. This is a regular treatment every month or every 2 months for year after year after year. Now, there may be reasons why we might wish to suspend treatment or not, and I'll come on to those. But for the time being, when patient who is eligible and we have a licensed agent, I think the important thing for people on the call is that if you do need it, you need to be thinking for the long term. This is not a short-term gain. Now, as I said, it doesn't halt the condition, it slows down the progression. But that's important. If you've got the center of your vision here, my finger, and you've got an area of worn out here, you can still use the vision here. But as that big area of atrophy gets closer to the center, then obviously the center becomes involved, and that makes it difficult for patients reading. So for instance, if you're reading the word Mississippi, you will miss a few of the letters. You might start with the MI and then you get to the S and you're not sure where it is, and you have to look to the side, and then you see the PP and you go, oh yeah, it's Mississippi, but then you've lost where you are along the line. And so reading is one of the things that patients often miss significantly when the center of the vision or these areas just close to the center are badly affected. So, but if you've got a lesion or this area worn out close to the center of the vision, if we can slow down the progression, we can maintain that remaining vision for a longer period. And we think it slows it down around about somewhere between 20 and 30%, maybe 35% in conditions in patients who have got atrophy very close. Some very interesting data that we've seen in the last 2 or 3 weeks has shown for patients who are slightly further away, but still threatening the center. So the area of atrophy, the area of wearing out, is slightly further away, seems to have even a greater effect. And we found that maybe we slow down progression by maybe 50%, which is quite a significant thing. What that actually manifested in our patients in the study was that if you came along and you had this area of atrophy and it was further away from the center of the vision, if you don't have treatment, that gradually affects the center of the vision. And we know from UK studies that if you have severe atrophy in your eye, then within 2 years, 2 out of 3 patients are affected with their driving vision. That's a significant number. 2 out of 3 patients who have severe atrophy progressing. Now, if we can slow that down and buy a year or 2 vision, then that makes a significant impact for patients. If I could say to you, I can give you a year or 2 years extra vision, then that makes a big difference to anybody. And that's where we believe that the cost effectiveness, both for individual patients, but also society as a whole, will have its benefits. We can keep people driving, if we can keep people reading, if we can keep people enjoying the hobbies they wish to do, then that will manifest itself in, significant improvements that, unfortunately for NICE, we have to measure that in monetary terms. But if we can keep doing those activities and reduce the support that's needed for patients affected with this condition, then that, we hope, will justify it being approved by NICE. As I say, time will tell, and it will go through a rigorous process. So we can halt progression. We can't stop it. Neither can we reverse it. Now, there are studies looking at trying to reverse the loss. So if your progression of this atrophy has affected the center of your vision and you've lost central vision, we can look at stem cell research and pigment epithelial cell transplants, and that's been going on for many years now to try to restore some of the function. And there are some very exciting areas around that, areas of research, but in reality, they're not here yet. I mean, they are being done in human patients, but they're not here as a treatment. And I will be honest, I don't foresee them as a treatment for the majority of our patients for a few years at least. So I think, whereas Syfovre, in slowing down the progress and having that, I think we're going to have that as a treatment in the next 6 to 9 months to slow down the progress. So we can't halt it, we slow it down. We don't necessarily, we have to identify who will benefit from it, even though we don't have it now. We're starting to say, can we identify patients who may be suitable, put them on our systems and go, yes, Mrs. Smith may be suitable. If it's licensed, we'll call Mrs. Smith and ask Mrs. Smith to come in. That's what we're aiming to do that. Now, that's us as ophthalmologists, but I think as patients who have got this advanced form of dry macular degeneration, I think there's an element of that you may be empowered to start looking at that yourself. So if you are being told that you've got dry macular degeneration, one of the questions you might be wishing to ask your ophthalmologist or your optician is, okay, I've got dry macular degeneration. Do I have the advanced form known as geographic atrophy? So if you know that, the next question would be, well, how close to the center of my vision is? And if we start to empower patients to ask those questions of their ophthalmologist or their optician, then the patients themselves will know. So they'll know, okay, I've got geographic atrophy, therefore I might be suitable, that it's this close, so therefore if NICE says, if it's this close, I may be eligible, if it's this far away, I won't be, you will know yourself whether you may be considered eligible. And then you might go back to your optician or your ophthalmologist and say, okay, this is what I know now. I've got geographic atrophy. It's affected one eye, and I know it's this close to the center of the other eye. Will I be suitable for it? And by asking your optician or your ophthalmologist, you will hopefully get an answer. Whereas if you're sitting there waiting for that answer to come to you, then the reality of the numbers is it won't necessarily happen. So I think empowering patients at this stage to know about it, ask the right questions will be key. And then for opticians, we're trying to educate both the company, ophthalmologists, the Royal College of Ophthalmologists are running seminars to try and educate both ophthalmologists and opticians about the condition and the treatments, the Syfovre treatment, and who may be eligible, and how to spot somebody who's advancing rapidly and who's somebody advancing a little bit more slowly, and we may wait a bit for treatment for those patients. And the way we're doing that is primarily we're checking vision and doing the special OCT scans. Now, many of you people on the call will have had scans. Now, opticians are doing scans regularly when you're attending them. They've been doing it looking for other things, not necessarily geographic atrophy, but now I think the tables will turning and they will be starting to look at these areas and looking at, as I say, looking for how close it is to the center of the vision, how advanced it is, and how progressive it is. If it's progressing rapidly, then that might be a red flag and maybe something that may need to be referred into the hospital eye service. So patients are learning, opticians are learning, and ophthalmologists are learning. And there's been a rapid understanding and a rapid development in this area, as I say, in the last few years. And now we're having to say, okay, these are the things we're going to need to do. So I think, so for you as patients on the call, or people affected with macular degeneration, certainly this dry form, you need to identify whether you have the advanced geographic form and how close it is. And then possibly when you do have a scan, maybe asking those questions. Do I have geographic atrophy? How close it is? One thing you could do, and many patients now have, smartphones where they can carry around in their pocket. And if we're not at a stage where you think that the opticians and the hospitals are linked up as well as we would like. And so transferring of images from an optician to a hospital, although in principle sounds easy, and in some areas it has been developed and improved, in many cases is lacking. But a mobile phone, you can take a photograph of the scan on your phone. And so what I would recommend is if you're in your optician and you're having a scan, you say to the optician, do you mind if I take my phone here? And do you mind if I video the scan? And so on all the scans, there's a little button at the bottom generally where they can because we don't do one scan, we do many scans, but there's a button called a video button where it scans through all of them. And if you video that scan, then when you come to see me or a colleague like me in your local area, you can say, well, Mr. Pearce, this is what it looks like on the 16th of May in 2023, and you can show me. And that will help me go, oh, I can see how big it was there. That's useful because now it's either the same size, which is reassuring, or perhaps it's got much larger, and that might be a concern. And so I think those things can be done now. And many people have phones that can video and take the photographs of the scans. The opticians don't like to give the scans out because, they don't always have printers, etc. And this idea of them sending them to the hospital sometimes works. But if it does, they send one image. They don't get all the images. So I think people should be empowered now to start going, okay, do you mind taking a photograph? Or I'm going to take a photograph of the scans on my phone. It will stay there. And when you turn up at the clinic, you will have a record that I can compare. And I think that is a very practical, very useful thing that we can be doing now, because, as I say, we're going to hopefully have a treatment in the next 12 months that might be eligible. And we're going to need as much information about your progression and exactly how quickly it's progressing and how close it is to the central of vision. So those are very practical things you can be doing now while we're waiting for treatments to become available. So it's an injection every month or every 2 months. It's a long term, doesn't halt the condition. It slows down the progression, but that progression might by central vision by 1 or 2 years improve, and that's a significant effect. And remember, it's 100 patients a day in the UK walking through our doors with this condition. So there are many thousands of patients, tens of thousands, hundreds of thousands of patients out there in the community already with it, but 100 patients each day happening with it. So that's key. Now, the injections, as I say, tolerated very well. Patients manage them surprisingly well. Are there any risks with it? Well, any treatment we give will carry a risk. Infection, hemorrhage, retinal detachment, all these things are potentially possible. The serious problems where you lose significant vision due to an infection or a large hemorrhage are thankfully very uncommon. Maybe 1 in 1,000, 1 in 2,000. Now, if you're that 1 in 1,000, it doesn't matter how uncommon it is. It is a significant problem, but it thankfully is very rare. So it has to be taken into account. But in reality, we would, if you were an aunt of mine and asking me, oh, Ian, should I have this? I would be saying to you, if I believe that it's going to halt and slow down the progression, then the risks are quite small in relationship to it. So I think there are risks, and you have to be aware of it. There is one other risk, though, that is key, and that's why I've left it to the end, is we're giving this injection which affects the immune system in the eye, and that stops the atrophy developing, slows down the atrophy developing. But what we've found is it also affects other changes in the eye. And actually, you might actually be stimulating some growth of blood vessels, so that you might actually be increasing your risk of wet macular degeneration. So if you're sat in front of me and you have the advanced form of dry macula, known as geographic atrophy, you have about, each year, a 3% chance of developing wet. Okay, so it's not that if you've got dry, you can still develop the wet. So it's a 3% chance that you will develop wet in that eye on average. Now, if I'm treating you with these injections, these complement inhibitors, then we actually increase that risk. And we think it's roughly, certainly with Syfovre, up to about 6%. We actually double the chance, but it's still a low chance. But that 6% is for 1 year. And then, of course, you might get another 6% the next year and then another 6%. So there is a growing risk of wet macula developing with the treatment. But remember that the risk of wet macula is developing is still there anyway. It goes from 3% to 6% to 9% each year anyway. By giving you the treatment, what we're doing is increasing that risk to 6%, 12%, 18%, 3 years, etc. So there is a risk. And that, in the studies, when we saw that, patients still continued with the treatment, and we gave them treatment for the wet macula, and their vision still stayed stable. So we were reassured by that. So we've got to tell patients that there is an increased risk of wet macula. You've still got risk, but you've got a slightly increased risk. That we will be monitoring you very closely. We're not just going to be treating you, we will be monitoring you very closely and looking out to see if there's any early signs of wet macular degeneration. And if there is, we will treat that. And then we will discuss with you about how we treat that, and do we continue the treatment for the geographic atrophy, the advanced form of dry macula. And as I say, in the studies that occurred, patients were treated both for the dry and the wet, and they stabilized vision. And we didn't feel that the developing of the wet macula led to a poorer outcome. We actually found that we were able to stabilize it. And as with all wet macula, if you pick it up early enough, we can help prevent the problems occur, or certainly significantly reduce the chance. So you will be monitored closely, we will be looking for it, and we will be treating it if that happens. So that is a real risk, and that's a risk that we'll have to have discussion with all our patients, and you will have to decide, and you'll have to, make that joint decision with your physicians. But, you'll need to be helped along with that, and we'll need to, as a community, work out how we're going to manage that. Do we think it's acceptable? I can say that in my own experience, I think it's often hard to predict the future. So if I can try to halt the progression, if there is an increased risk, if there's 3%, let's say you go to 6% chance of wet, that means 94% of the time in that year you haven't developed wet. So that's the majority of patients. And so even though there is a risk, the majority of patients are not exposed to that risk. And I think that helps us in our understanding of how do we feel it's acceptable. I think for the majority of patients it will be acceptable, but every case will have to be considered on its own merits. So you know now about dry macular degeneration, you know about the advanced form, the geographic atrophy, you know that there are some patients who advance quickly and some are a little bit more slower. You know that many patients are having scans done in the community, you're having scans done, and that you could take a video on yourself, you'll be able to record those. That will give us information should treatments become available in the next 12 months. And then we will be having discussions with patients if it's approved, and if NICE say we can treat a group of patients, we will be hopefully seeing those patients at a timely manner and trying to work out how, with you, the best way of delivering this treatment. But it will be injections for the moment in the eye. It will be long-term, and you'll be monitored, and we will slow down the progression to a point where, for certain categories of patients, we slow it down to by maybe a year or two, significant driving vision, being able to carry on reading, etc., etc. And those are going to be key. And there are some risks, as I've said, particularly the development of wet. So remember, though, it's not that we've given you wet macula. There's still a 3% chance without treatment that you will develop wet macula anyway. What we're trying to, with the injections, try to slow down the dry, you increase that risk a little, and we'll just need to be cognizant of that. So that's what we hope we'll be able to deliver in the next 12 months. That's Syfovre. There are other agents going through. There's another drug from a company called Iveric Bio that is a very similar, it's a complement inhibitor. It works slightly further down the pathway, on the complement pathway. It is an injection into the eye that is going through the US FDA process at the moment. And again, that may well become a licensed alternative. So we have got that coming available. We've got other treatments trying to affect the complement system. One of them is where what we're doing is we're taking a gene that a particular gene called complement factor I, and we're putting that in a virus, and that virus is then put in at the back of the eye underneath the retina, and that virus then puts the new gene in cells at the back of the eye, and the cells, hopefully, or there's evidence to show that those cells start producing this complement factor I, which seems to slow down the immune response. So that's a study that we're recruiting for in the UK. There have already been UK patients treated with this, but that's a surgical operation. It is putting a gene in a virus and putting that virus in the eye to spread the gene in the eye. And then that gene gives off this complement factor I, which slows down the inflammatory reaction. So we don't know whether that will prove to be a benefit, but we are recruiting patients for that in the UK. We're doing that. We're hopeful that will have some effect. Now, whether that will become a treatment in 5 years' time, I don't know. But I'm trying to show you that there are lots of areas. We've got the gene transfer therapy. We've got the Syfovre that I've already mentioned that is going to be the first treatment for dry AMD. We've got other injections coming along, like this Iveric Bio-1, that may affect other areas. We've got stem cell, pigment epithelial transplant, and there's a whole host of other treatments, including tablets that we're investigating to see whether they will slow down the progress of the geographic atrophy. But all of these things are in earlier phases, and in my experience, we won't see them for at least a few years before we actually get them available. Whereas Syfovre, and the whole point of this evening's webinar, is thankfully around the corner for us, we hope. And that will be important for you, but it'll be also important for me as an ophthalmologist practicing in this field to try to work out the best way treating patients and trying to make it an easier and transition to slow down this devastating disease. So on that note, Kathy, I'll hand back to you and we'll take the questions.
Thank you very much indeed, Ian. That was incredibly instructive. Thank you so much and so clear. We do have an awful lot of questions, so short answers, Ian.
Yep, I'll try my best.
And I'll try and cluster these as much as I can. So a lot of people are asking whether, with their particular circumstances, for example, somebody who has glaucoma, somebody who has already had a cataract operation, somebody who has had AMD for 18 years, we don't really, they're asking if they're going to be suitable for this treatment. And the fact is we don't really know exactly yet, do we?
No, we don't. I mean, that's the key. We don't know whether it will, well, there's two steps. There's the licensing of the drug, and that will say, is it available and who will it be available for? The license in the US is quite broad. Basically, if you have geographic atrophy, then you can be considered as a patient for it. So I think the incidences that you've described, the previous treatments, wet macular degeneration, glaucoma, I suspect you will be eligible in terms of licensing. What we don't know is what NICE will say. NICE may say that we're only treating. What we found is that once your center of your vision has been affected, the atrophy doesn't start, it stops growing. I mean, it doesn't exactly stop growing, but it marches towards the center of your vision. Once it reaches your center, it tends to slow down. And so the horse has already bolted by the time it's got to your center of the vision. So it may be, and I don't know, but it might be nice to say, look, if it's affected the center, we don't think it'll be cost effective. And that will be, unfortunately, many, many patients. But they may say, well, okay, it's reached the center in one eye and we can see what happens. You lose the center of the vision. If it's getting closer, we should stop it before it advances and affects the center. So it will be difficult to know who it will be who it will be suitable for. My gut feeling is that for the majority of people where the center of the vision has been affected, I don't think treatment is going to make a big difference to that eye. Now, there is an argument that, you know, if you've got a small area, even though you've lost the center, you don't, keeping that small rather than a big area of loss of center will be a benefit. But as I say, once it reaches the center, it often slows down. So I suspect for people who are affected in the middle of the vision, in that eye, it may not be available. But the conditions you mentioned, all those, I don't see any reason specifically why you won't be eligible in terms of other conditions. We'll have to monitor you differently, but it will be able to offer it if we think there's useful vision to save.
So things like one patient has got, one person here has got, is having chemotherapy for blood cancer. So because that destroys the immune system. This is an immune-related thing, not relevant particularly in these
No,
sectors.
I mean, there's always a fear. Any patients on chemotherapy or immunosuppressed, giving an injection into the eye. Remember, I said there's this risk of a 1 in 1,000 infection. There's always that concern. Could we, if you're immunosuppressed, would that increase your risk of infection? The answer is it might do, but in practice, generally it doesn't. So I don't think that if you're on chemotherapy or you're immunosuppressed, I suspect we'll be able to still give you the injection. And because the injection is only going into the eye, even though we're affecting the immune system in the eye, we don't believe there are other effects outside of the eye in terms of triggering off infections elsewhere. So I think that's reassuring. For most of those patients, they'll be suitable.
Quite a lot of people are pointing out that, of course, at the moment, people with dry AMD or geographic atrophy, this term that we're all going to have to start getting used to, aren't we? Geographic atrophy as a subset of the dry AMD spectrum. It's part of the dry AMD spectrum, I suppose. That they're not routinely monitored in hospital. So how on earth are we going to find these patients? People who've been through the system and been discharged say, no, we can't do anything for you, go away. How are we going to make sure that the patients who are eligible for treatment can actually be found?
I think that's the key to this. How are we going to do it? What I do know is that I don't want to have my clinic with 100 patients in it who may be eligible, and there's only one or 10 of them are eligible, because they may be at the end of the queue. And so by the time I've got through these 90 who didn't need to be here, they may not be eligible because they've advanced too much. So we've got to be realistic, and we've got to be mature and professional in how we manage this. But I think we do have in the community, we have a whole host of optometrists who are seeing patients regularly. So many patients have a check at their opticians once every 2 years. Now, it may be that has to be in certain categories of patients. If you're known to have geographic atrophy, they may need to be seen more frequently. And I think I'll be honest with you, I don't think there's going to be a magic, decision saying, right, okay, everybody over the age of 80 with dry macular degeneration will get an optician visit in 6 months. I just don't think that's going to happen. Realistically, if I think an educational system is saying, right, if you know that you've already got advanced dry macular degeneration and known as geographic atrophy, then I would recommend patients themselves empower themselves and go, okay, I need to get it checked. Now, of course, not everybody can afford an optician visit and then a scan. This might be somewhere in the region of £50, and so it's not everybody's can afford that. But for those patients who can, I would advise that in the interim, while we're working how we do it, then that actually probably is money well spent in terms of monitoring your own condition. But you need to know what questions to ask. You ask the optician, have I got geographic atrophy? Yes or no. Which eye, right or left, both? How close to the center of my vision? Can I take a photograph or a video? Because a photograph is just one slice of the scan. I want to see all the slices. I think that's something we can do now. We don't have to wait for a government decision to decide how we're going to work through this system. And although it's not ideal, and my left-wing politics are rather left, so I don't want to encourage patients to say, oh, this is how you should do it, you pay for it yourself. But I will be honest, I am a pragmatist, and at the moment, I think patients can be empowering themselves in doing that, because a lot of that's being done. It's just not being collected. Patients are not asking the question. The scans are just done and then sometimes stored. Let's be recording them. Keep them on your phone. Bring it to me when you do get referred, if there is a progression or it's being picked up. And then I can spot how quickly it's progressed in you. And I think that will help you make a decision, should I have it? And me, should I recommend it?
So that's very interesting. And one question has come in because lots of people use Amsler grids, don't they? Are Amsler grids able to detect this geographic?
I'm not a great believer in Amsler grids. So Amsler grids, and I know the Macular Society has it on the back, so I'm very conscious of that. The Amsler grid is a grid of straight lines and horizontal and vertical lines. Well, the whole world is made up of horizontal and vertical and straight lines. Windows, door frames, mirrors, everything's straight lines. The important thing is not to necessarily look at an Amsler grid. The important thing is to cover one eye once a week. Now, if you've got dry macula, when you cover one eye, it's maybe a bit blurred, and there may be some problem. If you develop wet macula, then suddenly you get a big area that suddenly goes. It's not, oh, is it better or is it worse? It's, oh my goodness, where did that come from? You only notice it when you cover your eye. So I'm a great advocate of, I'm not worried about whether you look at an Amsler grid or whether you just look at your window frame or your door frame or your mirror. The key is to cover one eye and to do it once a week. If you go, that seems okay, don't worry. If you go, it might be a bit worse, see your optician. If you go, oh my goodness, then you need to come and see me within 2 weeks. Now, that's primarily works very well for wet, at picking up the wet, okay? But for dry, it's a slow progression. And so what happens is when you cover your eye, your brain, if there's a bit of missing, it often fills it in and it adapts relatively well. So I'm not sure that Amsler monitoring at home will pick it up very well. I think if you do cover your eye and you notice a big change, you need to be seen because that might herald any other problem. But to cover one eye once a week, use an Amsler if you want to. The Macular Society leaflets have it on the back. Use that if you wish to. But the important thing is cover one eye, just check it. Don't get paranoid, but be vigilant is what I tell my patients. And if you notice, if you're not sure, go, oh, not sure, see the optician. If, oh my goodness, you see the eye doctor within 2 weeks. I think it will be hard for patients to monitor. I think that realistically, you need to be asking the questions, have I got the advanced form? How close is it to my vision? Can I take a photograph? I think that will empower you. Now, you know, there may be apps and things like that the Macular Society could develop and help, and patients could have them on their phones. But I think as long as you know the information, then you will be able to go, oh, hang on. Because the next time you go to the optician, you'll go, well, is it getting worse? And how quickly is it worse? If it was 250 microns away, and now it's 100 microns, you don't need to know what a micron is. If it's gone from 250 to 100, you know that's progressing. And therefore, armed with that information, you will make a decision of how important and should you be referred, or at least ask the question, oh, should I be referred? And that will help the optician decide and help me decide how quickly I should see you.
It looks as though under the plans for the NHS generally that direct referrals from optometrists straight into the macular services are in fact probably going to fade away a little bit, and there's going to be a triage system, isn't there now, really, to get people. So I mean, I'm a bit worried about that setting in more phases into the process and may slow things down. But on the other hand, when we have so many patients, it is important, as you said earlier, that the right people get through to the clinic. Given how many, one of the questions, very abstract question really, can the system cope with this? Are optometrists going to be able to give these injections, or is it going to rely on the hospital services entirely, which we know are already very, very full and overflowing, aren't they?
I think anybody can be trained to give the injections. As you know, in the UK, we're quite unique, not unique, but certainly in many parts of the world, you have to be a doctor to give the injection. The UK realised early on to provide treatment for wet macular degeneration that we needed to train people. And so many, in the UK, most injections are given by nurses or other allied health professionals, which can include hospital optometrists. We don't do them in the community in opticians themselves giving them at the moment. But can they be trained? Yes, of course they can. There's no issue with it. I mean, it's a skill like any other skill. The key is in the diagnosis of who needs the treatment. And that's where I think ophthalmologists are experienced at. And so I'm not too worried about who delivers it. I think at the moment, I think the hospitalized service should be where that decision making relies on. I think there is a triaging or refining of treatment. So I don't want 100 patients and only 10 of them turning up at my door. I want somebody to have worked out the 10, but I do want that 10 to get to me quickly. I don't want them to go to one optician, to another practice, for two reasons. One, it slows down their progression to me. And two, there's no money left by the time they get to me, because I paid person A and I paid person B and I paid person C. By the time it actually gets into the hospitalized service, there may not be a hospitalized service funded. Now, that's a political issue, but the reality of it is you've got to be careful about refinement systems and developing them appropriately, making sure patients are well trained, making sure patients are not over-treated, because once you're on the treatment, you're right for years. What we don't want is people who don't need this because that's taking resources away from the health service. So that's why I think the decision making of who needs it is that's a big decision. The actual delivery of it, I think, can be, commercialized in terms of how do you make sure you provide it enough to enough people in the country. Decision making is still where ophthalmologists have their role, I believe. But it's a decision we're trying to work through. But it's not as straightforward as we might think, as you've implied with your own answer.
So just a couple of running out of time a little bit, so I'm going to
Yep.
just 3 very important things before we well, no, 3. The next 3. Several people are referring to the fact that they have already been diagnosed with wet macular degeneration, but they had dry AMD before that. So will they be treatable for the dry element of their condition if they already have wet macular degeneration? We
won't fully know until NICE decides, because they may decide that risk is too much and may have a cost implication. But in reality, in the studies, if you'd had a history of wet in the past, as long as you weren't active at the time. Now, let's say you had dry, you developed wet, we give you treatment for the wet and you're now stable, then in theory, there should be no reason why you couldn't have the new treatment on top of that to slow down the progression. The answer as to how much that benefits you, we don't fully know, because if you were active, you wouldn't have been in the trial. If you've been previously active and became inactive, you would have been in the trial, and we found that those patients do well. So I think it's a very nuanced question, and we don't know the answer to it. I think we will look at, as we do with all cases, we'll look at individuals. If you've lost vision in one eye due to atrophy, and you're getting more and more atrophy in one eye, even though you've got wet, if that's stable, there may be an argument to say, well, okay, the risk benefit in that individual patient is to treat. And that's where we use our judgment. And that's why I say about those decisions, they are nuanced and with experience and expertise, and they are critical for both the patient to be informed and that we make the decision to use our health resources properly. So I don't think it would be an absolute contraindication, but we'll have to work our way through those.
Okay, thank you. Several people have asked, what happens if NICE doesn't approve this? Would it still, let's assume it gets a license. If it's licensed but NICE doesn't approve it, would it still be available privately potentially?
Yeah, if it's licensed, but I've got to be honest, in ophthalmology, if it's needed and it benefits you, it will be likely to be provided on by NICE. So NICE are not there to restrict payment. What they're doing is to use health resources appropriately. And NICE get a bad deal sometimes that they're blocking. They're not. Patients in the UK have got access to treatments that they don't have in other parts of the world because of NICE, because NICE have said, yes, you can use it. In my experience, when it ultimately comes down to it, is the company will, in most of the drugs, say, well, okay, NICE will say, we can't afford it at that price, but we can afford it at this price. And then a negotiation goes on, and the company will come back and say, well, okay, here's a patient access scheme, and they give a discount to the NHS if you approve it. And that's quite acceptable. We can't afford it at X amount. If you give it us this amount, we'll use it, and we're going to use a lot of it. So there's a discount there. Unfortunately, I think that will happen. There will have to be likely to be a patient access scheme. Do I think NICE will turn it down? I don't want to preempt it, but I would be disappointed and I'd be surprised. I think NICE have supported most of the new treatments if the evidence is there. And I think the evidence is mounting for Syfovre, that it slows down the progression of blindness in patients. And that is hard, the figures will stack up for themselves. So I'm hopeful.
That's very encouraging. That's very encouraging. Now, we don't know what the cost is going to be yet. The price hasn't been announced. We did have a question from somebody in the US who has already had an injection,
right.
which is very, very interesting. I don't know what the cost is in the US, but often more expensive than it is here, I think. Quite a lot of questions have come in just at the end now, really about people concerned about the use of e-readers, of screen use, and are generally using their eyes.
No,
Whether
we're talking about wear and tear. So your natural thing is, well, let's stop wear, if that's my tire, let's stop running it on, doing thousands of miles each year. In the eyes, although we use wear and tear, and it is bad terminology, it is your eyes are made for seeing. I would strongly recommend that you do use your eyes. What happens is the eye is only one part of the visual system. You've got the eye, the nerve, and the brain. And so by using your eye, e-readers, whatever, trying to read, you are still keeping the rest of the visual processes very, very active. And that will certainly help your visual system. It'll help keep you alert and allow you to sort of like, if you see a distorted letter, you'll be able to say, oh, well, no, that is a T. It's not an X. You'll be able to see it. Whereas if you give up on that visual processing and that visual exercising, you will lose that. So I would advise you that I have no concern about using treatments. I think there's some key things. If you do smoke, don't smoke. Smoking aggravates and increases your risk of the development of the atrophy. Now, many patients will have smoked for years and go, well, it's too late for me. It is never too late to give up smoking. And there's good evidence that if you avoid smoking, so if you've got geographic atrophy, tell the rest of your family, do not smoke, okay? Because it runs in families, a bit more common, so they must not smoke. If you do smoke, giving up smoking will help. Eating a healthy, Mediterranean green veg diet helps. The supplementation with certain supplements, there's debate about whether that really shows any evidence for geographic atrophy. We do know that a good diet helps. Good quality sunglasses, that's helpful, particularly patients who had cataract surgery. You take the cataracts out, you have a clear lens in the eye, and everything's very bright. Good quality sunglasses to reduce the amount of ultraviolet damage. So I think those things are practical applications in terms of trying to help you. But using your vision for e-readers, fine. The only thing, when you're reading an e-reader, people get tired, and that's because when you're chatting, we're blinking, so we're refreshing our cornea, and so your eyes are not drying out. When you're reading an e-reader, you stare at it, that's one thing. The second thing is, it's because it's quite warm, the environment's quite dry. So when you're using an e-reader, maybe every 10, 15, 20 minutes, just look away, blink a couple of times, look out the window, and then get back to it. That would be my advice.
And screens, computer screens, mobile phones, laptops, there's no real evidence, is there, that's...
No, it's not. Honestly, I don't believe there's any evidence at all. But as I say, you stare at a computer screen and it's quite warm, the environment around it. So your eyes do feel tired, but that doesn't cause any damage. Just take a 5-minute break just to blink to refresh your cornea. That will help.
So we're reaching the end. I'm sorry we haven't been able to get to all the questions. We never can these days. There are so many. But I just want to say a couple of things as we close. First of all, if you've got a question about your own condition, you want to know more about nutritional supplements, for example, then, or anything about your condition, then our advice line is incredibly informative, and it's available 9 to 5, Monday to Friday. The number is, and I'll put it into the chat in a minute as well, 0300 30 30 111. It's on our website, macularsociety.org, so you'll be able to find it really very easily. I'll repeat that number again before I say good night. This session, in case you feel like you've missed something, you want to hear it again, it's been recorded, and it will be on our website in a day or two, and you'll be able to watch it again. Or, of course, tell somebody else about it. If you know somebody who you think might be interested in it, do spread the word and make sure that everybody who might benefit from it knows about it. Quite a few people have asked about taking part in clinical trials. If you're interested in taking part in clinical trials, you can register with our patient participation database. And again, if you call the advice line tomorrow or later on in the week, they will introduce you to the research team, and you can get onto the list on our database and get other information about how you can volunteer for clinical trials. It's a wonderful thing to do, and thank you very much for for offering to do that. It's absolutely essential to finding new treatments and cures, that we have people willing to take part in research. So thank you all very much. Ian, last question to you. What's your hope for the future for macular disease? What do you think is going to be around soon? Where do you see this going? Are you optimistic about the future?
I am optimistic, and I'm glad you've asked that question, because I was just looking through the chat of the questions we didn't get around to, and there's one that stuck out for me. It says, I'm 54, newly diagnosed with dry macular degeneration, and to be honest, I'm a little bit scared about the future. I would say to that patient, don't be scared about the future. We can't alter the future. The future is scary wherever we live in the world. There are many war-torn parts of the world facing problems now, and we can't, the future is always difficult. For macular degeneration, we have changed the future over the last 2 decades. We have completely changed it in terms of wet macular degeneration. We've changed it for diabetic macular edema. We've changed it for vein occlusions that affect the macula. That it's completely revolutionized. Now there's a long way to go. Many patients who have wet macular degeneration still lose a significant amount of vision, but we've been able to make a big difference for many, many hundreds of thousands. And I think we are on the cusp of making a big difference for many hundreds of thousands of patients with dry macular degeneration. We're at the start of a journey. There's lots more that we're going to know. One of the things that I've learned in my 30 years of being an ophthalmologist is if there is treatments that pharmaceutical companies pick up, then people, it's just the drive. The pharmaceutical companies go, okay, this is something that we can make a lot of money. The market for these treatments are billions of dollars worldwide. The benefit for patients is if there's billions of dollars involved, people get interested. And so there are many, many companies. I mean, there's a list literally of ongoing trials, 30 to 40, of potential treatments for dry macular degeneration throughout the world, whether it be gene transfer, complement inhibitors that we've been discussing this evening. There are many, many other parts of the pathways in the eye that were being targeted as treatments. So I think the future holds promise. Predicting the future is always difficult, so I'm not going to tempt fate. But I do think if I was 54 with macular degeneration, I think you need to be informed. You need to have a good ophthalmologist and a good optometrist who's going to monitor you. But I think the future is one of improving year by year by year. And because there are so many companies interested in this area, and as I say, part of that is because of the billions of dollars. And I don't fear that, because that will drive research. And driving research, we will get to where we want to be, for a future where we can slow down the progression of this condition and may be able to halt it and may be able to reverse it, which is the ultimate goal. So I think the future is promising, but there's a start of a journey, and we just need to see where it goes, and we all keep working as best we can to try and do it. Me as an ophthalmologist, you as chair of the Macular Society, and all the patients being involved who are, given many, many of their hours of the time being involved in clinical trials. It's made a difference. It's made a difference to them as individuals, but most importantly, to the rest of the community in the future. So yeah, no, I think the future's promising.
Thank you so much, Ian. Great session. Thank you very much indeed. I hope you'll come back and talk to us again later in the year or as soon as possible. Thank you for all your wonderful questions today. That number again for our advice line, if you want any other questions answered, 0300 30 30 111. And it's all on our website, macularsociety.org. Thank you all for your company tonight. Ian, thank you once again. Another webinar this time next month, so I hope you'll join us then. In the meantime, have a very, very lovely evening. Thank you very much, everyone. Good night.
Goodbye, everybody.